Hello, everyone. Thank you for being here today and for taking your time to listen to my presentation. I've been asked to speak about the ultrasound of non-obstetric abdominal emergencies during pregnancy. My name is Emmanuel Abiola Babington. I'm a sonographer at the University Hospitals of Leicester NHS Trust in the UK. Since my qualification, as a sonographer some years ago, I have been practicing as an obstetric and non-obstetric sonographer for a while. However, since the last 5 years, I have not done obstetric ultrasound. I still remember quite a lot of things from obstetrics, but it's not part of my daily practice. I do other kinds of ultrasound like the general abdomen and small parts, some vascular, pediatrics, and things like that. Which is why I've been asked to speak on the non-obstetric aspect of this topic today. It's important to mention that about 0.5 to 2% of all pregnant women will require surgery for non-obstetric acute abdomen. And if care is not taken, complications could occur as a result of misdiagnosis or delayed diagnosis of these pathologies. So it's important that we as sonographers are able to recognize these pathologies and to be able to diagnose them when tasked. Like I said, I don't do obstetric ultrasound anymore. However, I have huge passion for clinical ultrasound. I love helping my patients, like every one of you who is here today, because I understand we're all here due to the passion that we have for the profession. I also have passion for teaching my colleagues and training, and also academic research writing. So what I've done is I've categorized the different courses of non-obstetric abdominal emergencies during pregnancy into different systemic categories. So gastrointestinal causes, urological, hepatobiliary, gynecological, and obstetrical. I understand I don't do obstetrical. However, I decided that it's important that I mention some very serious obstetrical emergencies in pregnancy during this lecture in order to give it some completeness. So when it comes to the gastrointestinal causes, acute appendicitis is generally the most common cause of abdominal emergencies during pregnancy. The other gastrointestinal causes, which are a bit rarer than appendicitis, includes intestinal obstruction, IBD, gastroenteritis. I've included ascites here not because ascites is a disease. Ascites is not a disease condition on its own. Ascites is the presence of fluid in the abdomen. However, the presence of ascites during pregnancy indicates something significant going on. So it's important that if you do find ascites during pregnancy, as sonographers, we try to look around and see why there is ascites and what's caused it. Because in most cases, it would mean that there's something significant going on and the patient would require urgent medical or surgical attention. So appendicitis during pregnancy. The appendix is a long, blind-ended tubular loop of bowel, usually in the right iliac fossa. The base of the appendix attaches to the cecum, and next to it you have the terminal ileum attaching to the same cecum as well. Appendicitis during pregnancy is a potentially lethal abnormality. So as sonographers, it's important that we are able to understand the variation of the anatomy of the GI tract during pregnancy. Because appendicitis is more common in the second and third trimester, particularly in the second trimester during pregnancy. The gravid uterus growing into the abdomen would have deviated the general anatomy. So the organs in the abdomen would move to give room for the gravid uterus. So you might end up finding the appendix in a slightly atypical location, most likely a bit higher than the usual McBurney's point that would expect it to be. So also it's important to remember that you could have an antececal or retrocecal appendix. So when you're looking, if you don't find the appendix a bit more anteriorly, try to look to the side or most likely rotate. Ask the patient to go onto a lateral decubitus, left lateral decubitus position, and then you scan the right side following the loop of the bowel loops and see if you can find where the appendix is situated. So appendicitis is the leading cause of surgical emergencies during pregnancies. Patients would normally present with symptoms of right iliac fossa pain. However, in some cases, the pain symptoms could be non-specific, and you could have patient could have right upper quadrant pain instead. I remember, due to the change, the movement, the adaptation of the anatomy, of the GI anatomy for the gravid uterus, you can have the appendix a bit higher up towards the right upper quadrant as well. So it's important to bear this all in mind. On ultrasound, when the appendix is inflamed, you would find it measuring above 6 millimeters in anterior-posterior dimension, and you measure from outer wall to outer wall, which I would explain shortly. So appendicitis can be uncomplicated or complicated. Uncomplicated appendicitis is when you have an inflamed appendix on its own. So some authors call it wall appendicitis. So the wall of the appendix gets inflamed, measuring above 6 millimeters. While complicated appendicitis would usually have the presence of an appendicolith, which is a stone in the appendix, or you could find presence of fluid, periappendiceal fluid, which could denote possible perforation, and you could also find a breach in the wall of the appendix, which clearly denotes appendiceal perforation. Appendiceal perforation is very dangerous in pregnancy, as this can lead to fetal and maternal undesirable outcomes. So it's important that we do look out for these things, and we try just finding the appendix is not enough, to try to look around and see the individual layers and see if there's any compromise, presence of appendicolith. I also included a screenshot of a chapter that I wrote last year on this topic. I think you might find some points in there helpful. You might find some helpful tips on how to scan the appendix and how to identify the different ultrasound appearances of appendicitis. So here we have some ultrasound appearances of an inflamed appendix. So up here is the longitudinal view of the inflamed appendix. So the appendix has 5 layers, just like the rest of the bowel. So they tend to overlap. So hyperechoic, hyper. So the outermost hyperechoic layer is the serosal layer, and then you have the muscularis propria layer, which is hypoechoic, and then the hyperechoic submucosa, then hypoechoic mucosa, and the hyperechoic mucosal interface, which is the layer of the lumen. And transversely, you would find the appendix looking like a target sign. And it's important that you take your measurements from the outer wall to the outer wall. I cannot overemphasize on this, because if you do, I've seen cases where we've measured from the submucosa to submucosa, and that would lead to false negative results. And as you know, it could be devastating for the patient and the fetus. So it's important that we measure from the outer to outer. Also, we can have a look here and see the presence of echogenic mesenteric fat stranding around the appendix, so around the inflamed appendix. So when there's inflammation, it irritates the mesentery, the adjacent mesentery, which makes it appear on ultrasound as an echogenic stranding around it. And down here, you can see the inflamed appendix with the presence of an appendicolith. So appendicolith, like every other calcification in the abdomen, would normally show evidence of posterior acoustic shadowing or even twinkle artifact in some cases. Also, I need to mention that you can find appendicolith in normal appendixes. So the primary parameter criteria to check for an inflamed appendix is that the appendix actually measures above 6 millimeters. So I would move on to intestinal obstruction. This is much less common than appendicitis in pregnancy. In fact, I read an article where they said an average surgeon would encounter about 2 to 3 cases of intestinal obstruction during pregnancy in their entire career. So it's not that common. But it's important to know what it looks like, and if we do find it, then we should be able to make the diagnosis properly using ultrasound. So intestinal obstruction would mostly be caused by the presence of adhesive bands, which could occur in individuals with history of previous abdominal surgeries, and in some cases it could be caused by volvulus. Volvulus is when the bowel twists on itself, leading to an obstruction of the proximal bowel loops. And some other causes could be intussusception, strangulated hernia, diverticulitis, and so on. So in intestinal obstruction, the bowel lumen measures above 25 millimeters in diameter, and the lumen are usually fluid-filled, distended, with prominent plicae circularis or valvulae conniventis in the jejunum and ileum. And you might find evidence of hyperperistalsis, in some cases hypoperistalsis, depending on the location of the obstruction. So I'll move on to acute pancreatitis. Acute pancreatitis is quite lethal. It's an inflammation of the pancreas. However, it's also very rare in pregnancy, and it's a clinical diagnosis most times, and the clinicians only tend to depend on imaging in order to understand the extent of the inflammation or to find the root cause of the inflammation. Now, acute pancreatitis is usually caused by gallstones mostly, but there are idiopathic causes, and in some cases you find you have alcohol-induced pancreatitis as well. But in pregnancy, gallstones are usually the most common offender when it comes to acute pancreatitis. Also, imaging can help to clarify the diagnosis and also to assess the complications, which would include the presence of thromboembolism in the portal vein or splenic vein. So when you're scanning a pregnant woman with clinical symptoms of acute pancreatitis, it's important that we check the portal and the splenic vein to make sure we do not find evidence of thrombosis. And to do that, you basically just put the color Doppler on and follow the anatomy, the lumen, as you go. It's mostly occurs in the third trimester, which makes it a bit more challenging for us as sonographers, because obviously the gravid uterus is well within the abdomen this time, so you have to work your way around the gravid uterus to locate it. In my experience, you don't really find it's very difficult to find ultrasound appearances of acute pancreatitis, particularly during pregnancy. That's partly because with acute pancreatitis, the patient has symptoms of severe epigastric pain, and this can lead to the patient not being able to tolerate transducer pressure in the epigastrium, enough transducer pressure for you as a sonographer to be able to visualize the pancreas. So you end up not being able to see the pancreas. But if you do see the pancreas, it would appear bulky. When you measure the body of the pancreas, it would measure above 24 millimeters in thickness, anterior-posterior thickness, and you might even find some hypoechoic or anechoic pancreatic exudates, which is basically fluid seeping out of the pancreatic tissue to the surrounding peripancreatic region, and that's because the pancreas doesn't have an outermost covering. An outermost covering around it, so you find the exudates all around the pancreas. And the most important thing we use ultrasound for when it comes to clinical diagnosis of acute pancreatitis is to check for gallstones. So you might even have patients who's had maybe in some cases CT scan, particularly during early pregnancy, or non-pregnant. And then they send them down to ultrasound to check for gallstones that might have caused the pancreatitis. This is very common actually, but during pregnancy, ultrasound would normally be the first imaging point of contact to use. So the patient will be sent to us, and then we'd have to have a good look around the pancreas. If you can see it, if you do see it, that would help massively, and you would find the presence of this hypoechoic or anechoic area around the pancreas, and also the body of the pancreas would be bulky if you measure from the outer to the outer wall of the pancreas. So you'd find that the body of the pancreas would measure above 24 millimeters in anterior posterior dimension. So, and like I mentioned, the main offender when it comes to acute pancreatitis is gallstone. Gallstones and gallbladder disease is the second most common or second leading cause of non-obstetric abdominal emergencies during pregnancy, after appendicitis. And the symptoms would patient would present with epigastric pain or right upper quadrant pain, and this could lead to serious complications like cholangitis, jaundice, gallstone pancreatitis, or gallbladder perforation in rare cases. I think I've encountered 2 cases of gallbladder perforation throughout my career so far, and in some cases you could find abscess formation. Also, when you're scanning the gallbladder, it's important that when you do find the common bile duct, you measure it. That should measure less than 7 millimeters in individuals that are less than 70 years of age. And if it does measure above that, then that could indicate the presence of a stone within the duct. So it's important that sonographers are able to follow the duct all the way towards the ampulla of Vata, next to the pancreatic head, where you would then most likely find the offending ductal calculus within the ducts, causing the proximal dilatation of the common bile duct. So it's important that we look out for this as well. And yeah, symptomatic cholelithiasis can lead to gallstone pancreatitis, and it could lead to 10 to 20% risk of miscarriage. And differential diagnosis obviously includes things like appendicitis, because as I mentioned earlier, appendicitis, the appendix could be a bit higher up, leading to and get inflamed there, leading to symptoms of right upper quadrant pain that could mimic gallbladder symptoms. And there are other possible differentials like preeclampsia, acute hepatitis, and the rest. So when you're checking for gallstones, it's essential that we look all the way, we check the gallbladder all the way to the gallbladder neck. That's because you could have an impacted calculus at the neck of the gallbladder. This, based on experience, this can be easily missed if you don't look closely. And the presence of that calculus, impacted calculus at the neck of the gallbladder, would lead to retained bile, obstruction of the bile from draining into the ducts as it should physiologically, and this could then lead to irritation of the gallbladder wall that would subsequently lead to gallstone cholecystitis and inflammation of the gallbladder wall, and could pass on to become gallstone pancreatitis, which is quite dangerous in pregnancy. So we should always make sure that we've checked the entire gallbladder outline all the way to the neck and back. So gallstones appear as calcification, echogenic calcification in the lumen of the gallbladder, in some cases in the common bile duct, as I mentioned earlier. And when there is cholecystitis, the gallbladder wall would appear thickened and edematous. Edematous in the sense that you have hypoechoic stripes within the wall, which shows presence of edematous fluid around the gallbladder wall. Normal gallbladder measures less than 3 to 4 millimeters in anterior posterior caliber. However, the abnormal gallbladder will measure more than that. I believe a number of you would have encountered cholecystitis during your practice. But the key things to highlight here is that you need to make sure you've ruled out the presence of calculus impacted at the neck of the gallbladder. If you do find gallstones, also try to ask the patient to change their orientation. So if you're scanning them in a supine position, ask them to go on to the left side and see if the gallstone moves. If not, you can ask them to sit up, or in some cases you can ask them to stand while you sit in front of them and have a look at the gallbladder again while they are in an erect position, to see if the gallstone drops to the fundus based on gravity impact. So this would help you identify if the gallstone is impacted at the neck or if it's a mobile gallstone. These are things that we need to mention in the reports. as you know, when you find any calculus. So the next thing I'll be talking about is inflammatory bowel disease. I won't really go too deep on this because it's a broad topic. It's also not that common during pregnancy, but it's important as sonographers that we know about it and we are able to identify it if we find it. So IBD, as is commonly known, comprises basically of Crohn's disease and ulcerative colitis. Now these two can pose, differentiating them can pose diagnostic dilemmas for clinicians and even radiologists as well, because they can be quite similar in appearances. However, they do have some classical ultrasound differences, and this will be based on your knowledge of bowel anatomy as a sonographer. So ulcerative colitis is the affect the bowel in a retrograde fashion. So you would normally find the inflammation of the bowel wall from the rectum or sigmoid colon, going backwards anatomically. So sigmoid rectum, sigmoid colon, the descending colon, transverse colon, ascending colon, that way. While Crohn's disease commonly affects the terminal ileum, and also it has a characteristic skip lesion appearances. So you could have focal thickening of the terminal ileum, and then you would find focal thickening elsewhere. Crohn's disease can also affect both small and large bowel, but it's commonly in the small bowel, while ulcerative colitis is commonly in the large bowel. In terms of ultrasound appearances, to this side, to the right of the screen, we have a segment of the large bowel. I don't know which specific bowel it is, but it could either be descending colon or transverse colon. But this is a classic appearance of ulcerative colitis. You would normally find hypervascularity within the wall of the bowel, within the bowel wall. The normal bowel wall would not show evidence of hypervascularity. You'd probably find a bit of vascularity here and there within the normal bowel, but you won't find hypervascularity. Also, a normal bowel would show evidence of peristalsis, and it will be thin-walled and easily compressible. But when the bowel is abnormal, like in this case of ulcerative colitis, it becomes very prominent. The moment you place your high-frequency probe on it, you would see it. Peristalsis is significantly reduced, or in some cases absent, and there's evidence of hypervascularity when you put the color Doppler on it. So then understanding the anatomy would help you determine what it is, if it's ulcerative colitis or Crohn's disease. And these two are chronic conditions. Usually when it comes in pregnancy, you would find it in women who already know they have it. They've been previously diagnosed with it. However, they could then develop acute flare-ups of the condition, which is where they then develop significant abdominal pain. Sometimes it's non-specific, so it's up to you as a sonographer to try to look around the gravid uterus, away from it, and check the bowel, follow the bowel anatomy. And I must reiterate that the bowel anatomy would have changed a lot due to pregnancy, particularly in the second and third trimester, but you can always work around the gravid uterus to find it. Now back to the sonogram. So to the left of the screen is an appearance of Crohn's disease. This is the terminal ileum in longitudinal orientation and then transverse orientation. The difference between the appearances of the terminal ileum when it's inflamed and the appendix, which are both within the same region, is that the appendix, if you follow the appendix down, you would find it having a blind end. So there will be a fundus at the end of the appendix. Meanwhile, the terminal ileum to the left of the patient would lead you to the cecum, and to the right of the patient would lead you back to the distal ileum. So it would continue with the rest of the bowel. So this is about similar to the appendix. The bowel has 5 layers. So you have the same one, hyperechoic, hypo, and hyperechoic layers. And when you measure from the lumen to the outermost layer, a normal bowel wall would measure about 3 to 4 millimeters max in anterior posterior diameter. while the abnormal bowel will measure above that. Some authors use 3 as their cutoff, some use 4. In my experience, the abnormal bowel would usually measure above 4 millimeters in AP caliber within the small bowel. The large bowel could measure up to 5 millimeters when it's normal, and the stomach wall could measure up to 6 millimeters when it's normal. But when it's abnormal, they would usually measure above that, and obviously you would find reduced peristalsis, or in some cases absent peristalsis. And if you put the color box on, particularly when you've reduced your color scale setting, or you're using microvascular imaging, or any of the any of the advanced vascular imaging on ultrasound, then you would find evidence of flow hypervascularity within the wall of the of the bowel. If you do understand the anatomy and you find the thickened bowel loop, then it's important that you check for any abscess or perforations, or just any, or even any abscess, perforation, fistula, or anything like that. So it's important that we look out for that as well. These are some of the common complications of Crohn's disease. While ulcerative colitis, you mostly tend to have toxic megacolon, which is more obvious to see on ultrasound if you do find it, and it's very rare as well. So I'll move on to the next topic. We're just going to touch on this gastroenteritis. I'm putting this there for you to know that it's one of the possible causes of abdominal emergencies during pregnancy. On ultrasound, you don't. In fact, it's a clinical diagnosis. Patients don't tend to get sent for ultrasound to check for gastroenteritis. That's because, like I said, it's something the clinicians would be able to understand, to deduce from clinical assessment of the patient. However, if you do find ultrasound, if you do find evidence of gastroenteritis on ultrasound, you would most likely be seeing things like thickened stomach wall or thickened duodenal wall. The duodenum is very easy to see on ultrasound. Once you try to locate the pancreas, it's between the left hepatic lobe and the pancreatic head and body. So you would normally find the duodenum, and then once you locate the duodenum in between, follow that to the left, and that would lead you back to the stomach. And you with a fluid-filled stomach, you might be able to easily measure the wall, but you need to measure away from the rugae, the folds of the wall, in order to get the accurate measurement. But like I said, gastroenteritis is a very clinical diagnosis, so you might not need to worry yourself much on it as a sonographer. But it's important to understand it as a possible differential diagnosis. And if you do find ultrasound appearance, then even better, describe what you've seen and write back to the referring clinician. So the next aspect is the urological causes of non-obstetric abdominal emergencies. So I've basically listed the 3 most common causes: hydronephrosis, nephrolithiasis, and pyelonephritis. Hydronephrosis is very common in pregnancy. In fact, you find it in even in asymptomatic pregnant women, particularly during the 2nd and 3rd trimester. And this is due to the physiological increase in the size of the gravid uterus as the pregnancy progresses, and this increase compresses on the ureters, the left and right ureters on both sides, and that leads to reduced flow of urine from the kidneys down to the bladder, which then retains the urine in the renal, pelvis and calyxes. So you then find calyxial dilatation and pelvic dilatation. Like I said, it's more common in the 2nd and 3rd trimester. But it's important that when you're checking for hydronephrosis, which is usually physiological in pregnancy, if the patient is symptomatic and the patient has signs of fever, then you should look into the fluid within the hydronephrosis to see if you can find any echogenic debris or collection which would indicate pyelonephrosis. And that's a medical emergency. That's going to need some treatment for that. So here is just some anatomical description, or just anatomical description of hydronephrosis. Also, it's important to also mention that in some cases you could have patients with multiple renal cysts. This multiple renal cysts could mimic hydronephrosis. It's a common mimicker. The difference is when you're scanning the kidney in hydronephrosis, everything connects, the fluid connects. Meanwhile, when there are multiple renal cysts or parapelvic cysts, they stand alone. So you would see the outline of each of the cysts. So just try to zoom in and look closely for that so you don't mix it up. So the next part is nephrolithiasis, which is commonly known as the kidney stones. This causes severe colicky flank pain. Patients will present with nausea, vomiting, and like I said, flank pain and absence of peritoneal signs. When you're scanning for this, sometimes kidney stones can be tricky to see on ultrasound. However, with the newer machines that we have nowadays, I find ultrasound very sensitive, much more sensitive at detecting kidney stones than they were 10 years ago. You know, when I was new to the ultrasound practice. In some cases, the kidney stones could show posterior acoustic shadowing, and while in some cases you could even find twinkle artifacts as well. So you just put the color Doppler on, and you find some twinkles behind, posterior to the stones. This would indicate clearly that you're scanning right on a kidney stone. So kidney stones could move from the kidney through into the ureters, causing obstruction. So if you do find hydronephrosis, generally it's normally advisable to try to follow from the renal pelvis, follow the proximal ureter. In a few cases, I have found, and a few of my colleagues as well, have found an offending kidney stone somewhere in the ureter. When you do find it, not only is it satisfying as a sonographer to see, because you know you've helped your patient massively and they don't need to go on to do any other kind of examination, particularly in pregnancy where the clinicians shy away from using CT scan due to ionizing radiation effect on fetus. So with ultrasound, we try to get as much as we can and try to help the patient as much as we can. So please follow the proximal ureter as much as possible, as far as possible. But I understand that the gravid uterus could obscure the visualization of the ureter. So this would depend on your skill as a sonographer, and in some cases your patience as well. Sometimes you might need to turn the patient from side to side and try to scan using a different window. That might help as well. So just some images of kidney stones. I believe many of us would have encountered kidney stones during our practice. So basically an hyperechoic focus within the kidney. In some cases it's as obvious as this, and that will be the first thing you see the moment you place your transducer on the flank. While in some cases you might need to use the color box to scan through the kidney to then check for areas of twinkle artifacts. If you do find it, then you would that would make you realize that you found a kidney stone. So if you do find twinkle artifacts, in my experience, I believe kidney stones are quite common in pregnancy actually, and they do cause the mothers quite a lot of pain as well. And based on literature, kidney stones, the pregnancy is lethogenic. So pregnancy encourages the formation of stones in the body. So you tend to have kidney stones, gallstones develop due to pregnancy, the hormones in pregnancy. So if patients develop pain, it's important that we rule out these stones in the gallbladder or in the kidneys. So the next thing I'll be talking about is pyelonephritis. So with pyelonephritis is an infection of the kidneys. It could affect one kidney and it could affect both kidneys. However, pyelonephritis, like pancreatitis, was more of a clinical diagnosis than imaging. The clinicians would request for imaging to see the extent in the kidney and to see how it's affected the kidneys, and also to check for things like abscesses or collections around the kidneys. But technically, it's a clinical diagnosis, and in my experience, I would say within the last 5 years, I've probably encountered 3 to 4 classic ultrasound appearances of pyelonephritis. And one of them is the case I've just put, the images I put on the site here, which I'll discuss with you shortly. So you would normally find, if you do find evidence of pyelonephritis in on renal ultrasound, then you would find heterogeneous perinephric collection in some cases. Sometimes you could find pyonephrosis, which is complex hydronephrosis. And also it's important that you compare both renal echo texture. So what I do is I would take a split screen image. On one side would be the right kidney, and on the other side would be the left kidney, right next to each other. And the affected kidney, because the patient would normally tell you which, where the symptom is. The affected kidney would look different, would look more heterogeneous, could look a bit more echogenic in parenchymal echo texture than the unaffected kidney. So it's important that you're able to compare both parenchymals. That could help you towards a more accurate diagnosis. And patients would present with flank pain and most times fever. So the images I presented, because I don't have images on pyelonephritis, and it's quite difficult to find classical appearances online as well. But this is a case I encountered 2 months ago. This is non-obstetric. In fact, this is a 67-year-old lady who presented with acute onset of left iliac fossa pain. Now, this patient has had renal transplant 30 years ago. So these are images of a transplant kidney in the left iliac fossa. And she was very, very unwell when I encountered her, but in a lot of pain in the left iliac fossa. And the moment you place the transducer on it, she jumped. So she also had fever and all the symptoms that comes with it. So you could see the heterogeneous cystic area in this anterior surface of the left iliac fossa transplant kidney, and around it, first you can see internal vascularity using power Doppler, and around it you can see evidence of fat stranding, which denotes some kind of inflammation going on in that region. Also, the patient had some tiny simple cysts, but that has been there for a long time, because she's had some imaging in the past, and the cysts were there, but this is new, and this is the offending cause. You can see the arrows pointing at the fat stranding around the heterogeneous cystic appearance of the kidney. And here you can see a twinkle artifact, which on 2D ultrasound did not reveal evidence of calcification, but this clearly indicates that there is some tiny calcification there, which was also reported. So pyelonephritis is not it's not commonly encountered in clinical practice. However, if you do find it, it's important that you're able to recognize the appearances. So you just need to take your time when scanning through the kidneys. Kidneys are relatively straightforward to scan, but also one of the most complex organs to scan, because it's easy to miss pathologies in the kidneys. So particularly when a patient is symptomatic, take your time to check for the patterns. So we move on to gynecological causes, but here I'm just going to summarize on these. Complex ovarian cyst. I'm sure a number of us have seen ovarian cysts. I'm sure every sonographer has seen an ovarian cyst at some point. Cysts are fluid-filled sacs, anechoic. Simple cysts will be completely anechoic, while the complex ones would include echogenic materials within the cyst. So this could range from hemorrhagic cyst to malignant ovarian cystadenomas and any nasty ovarian cysts. So it's important that when you do find a complex cyst or a cyst at all in the pelvis, you try to follow the cyst down to its origin to see if it's coming from the ovary. If you don't, you can look for the ovary on that side, the ipsilateral ovary, to see if it's related to the cyst. In some cases, it might not be related to the cyst. The cyst might be an adnexal cyst. or it could be from a different organ, like a massive cyst in the left kidney or something like that. So it's important that as a sonographer, you're able to locate the origin of that cyst. Just finding a cyst is not enough, and don't just assume, oh yeah, it's an ovarian cyst. You need to follow it and try to look for the normal ovary. If you do find a normal ovary separate, then you need to indicate in your report, or a normal left ovary was seen adjacent to the cyst, and the cyst measures this and looks like that, contains this, and on Doppler interrogation it shows evidence of vascularity, or it doesn't. You need to mention all that. Now, ovarian torsion is basically when the ovary twists on itself, preventing blood flow from its artery or drainage into the veins. So the ovary twists, the arteries are occluded, the artery is occluded, the vein is occluded. Now, what this does is, due to the lack of venous return, the ovary then gets edematous. So usually a normal ovary would measure less than 10 milliliters in volume, but ovarian torsion in the case of ovarian torsion, the ovary would measure much higher. I think the most recent ovarian torsion I encountered on ultrasound, the ovary measured about 220 milliliters. So it's there, it's in your face. You would see it. But it's a surgical emergency. If you do find ovarian torsion, particularly in a pregnant woman, she needs to be taken to the OR, to the theater, operating theater, as soon as possible. The ovary will appear bulky, it would appear heterogeneous, it would appear edematous, because there's no venous or lymphatic drainage going on at the time. And also, when you put color Doppler on, you won't find evidence of vascularity. I must mention that when you're checking for vascularity, particularly in slow flowing vessels, you need to reduce your color scale by a lot. If you don't, you would miss microvasculature, and you could misdiagnose things. Also, what I normally do is I use color Doppler, reduce my settings. Afterwards, I switch to power Doppler. And then if you've got microvascular imaging or super microvascular imaging or microflow imaging on your system, use those. Or if you've got B-flow, use that as well, just to make sure that you've used different, you have a multi-parametric approach to checking for vascularity of lesions. So if you do find an ovarian torsion case, you'd normally encounter the ovary being large, hypoechoic, heterogeneous, and with the absence of vascularity. It's an urgent ultrasound, urgent situation, and you need to escalate it as soon as possible. This patient needs to be reviewed by the surgical team. On a rarer note, some patients during pregnancy could have a torsion of the pedunculated fibroid. So this would normally appear as a subserosal fibroid, somewhere maybe in the fundus or things. But what you need to do to confirm the pedunculated fibroid, which I believe many of you would know, is to make sure that you can establish the presence of a stalk. So if you do find a subserosal fibroid in a patient without previous history of ultrasound scans, try to check that to see how the fibroid connects to the uterus. If there is a stalk and the patient is tender on that fibroid, or you find that the fibroid is looking heterogeneous and that's the site of concern, then you might be having a case of torsion of pedunculated fibroid, which is a surgical emergency in pregnancy. Patient would need to have the fibroid removed as soon as possible. On the contrary to that is rare degeneration of fibroids, usually with subserosal or intramural fibroid. Those ones tend to be managed conservatively. So if you have a patient with rare degeneration of fibroid, you would normally see the fibroid getting hemorrhagic at its center. So you would find the fibroid will appear hypoechoic around in its rim, and then the center would be hemorrhagic, anechoic, or heterogeneously anechoic. And this rare degeneration of fibroid occurs due to the fact that the pregnancy hormones are feeding the fibroid. Fibroid is increasing rapidly in size, increasing much more than its blood supply. So this then leads to hemorrhage of the fibroid. Now, the symptoms are similar to torsion of pedunculated fibroid, particularly when it's a subserosal fibroid. Personally, I've encountered rare degeneration of fibroid quite a lot when I practiced in Nigeria. Um, and the patient presents with the similar symptoms: pain, severe pain. And when you do the scan, you'd find that the fibroid, sometimes fibroid could even be a bit more hypervascular, and then the center would be hypo or anechoic, which shows evidence of rare degeneration. Usually, the pain will subside after a few days, but if it doesn't, then torsion of a pedunculated fibroid, in the case of subserosal fibroid, would be the most likely diagnosis for this, and in that case, patient will need to have urgent surgery. So I've also mentioned some of the main, the most dangerous obstetrical causes. I mean, I don't do obstetrics like I said, but I think without putting this, it makes the presentation incomplete. So we have things like retroplacental hematoma, which preferentially occurs in the setting of preeclampsia. And this basically presents as constant, intense, brutal abdominal pain with a hypertonic, the uterus would be hard as wood, and possibly even metrorrhagia. So when you're scanning, when you find evidence of retroplacental hematoma with hypoechoic or heterogeneous, hematoma kind of appearance, posterior to the placenta, we need to this could mean that the patient is undergoing preeclampsia, which is a surgical emergency. Also, you can have subcapsular hematoma of the liver, which is also a sign of preeclampsia, and it would present as severe abdominal pain, most times, or right upper quadrant pain. And in settings like that, you could have hemoperitoneum as well. And I must mention that with uterine rupture, this could either be primary or secondary. Primary uterine rupture is basically happens when people have had numerous pregnancies, full-term pregnancies. Back in the days when our grandparents would have 7, 8, 9, 12 kids, they tend to have higher risks of uterine rupture with subsequent pregnancies than nowadays, and that's the primary uterine rupture. Now the secondary one is on the rise due to the increased use of cesarean section in delivery. So that's why some clinicians would advise patients who have had multiple cesarean sections not to get pregnant anymore, and that's due to in order to avoid the risk of uterine rupture. And if that happens, it's a surgical emergency. There would be significant hemoperitoneum, and the patient would need to be treated surgically. Patient could present with vaginal bleeding as well, and the abdomen would appear deformed. And like I mentioned, there would be hemoperitoneum. So when you find hemoperitoneum, this is severe. Patient would have severe abdominal pain, and it could occur in cases of placental pancreata, and in some cases vascular malformation or hemorrhage from the endometriosis if that was present before. Also, ectopic pregnancy. I think that was the last thing I didn't mention on the previous slide. With ectopic pregnancy, it's very common. I believe virtually everyone listening to me would have encountered a case of ectopic pregnancy in their practice. This is the implantation of pregnancy anywhere outside the lining of the endometrium. It mostly occurs in the fallopian tube, but however, it could happen. You could find the presence of ectopic pregnancy in the ovaries or in the abdomen. And if a patient has had previous cesarean section, please look at the cesarean scar, because you can have ectopic pregnancy in there, and that would lead to that can lead to diagnostic or even treatment dilemma for the clinicians. Also, you can find presence of ectopic pregnancy in the cervix as well. Now, I must mention before I go that heterotopic pregnancy is the presence of ectopic pregnancy, presence of a normal fetus, normal pregnancy in the endometrial lining, coexisting with a twin outside the endometrium. So you could have normal pregnancy in the endometrium, and then you have another ectopic pregnancy in the fallopian tube. So the fact that we've seen a normal pregnancy in the endometrium doesn't necessarily rule out possible nasty complications like heterotopic pregnancy. So please, let's bear that in mind and always look around, and try not to rush with scans. So patients with ectopic pregnancy could have had previous tubal surgery, previous ectopic pregnancies. History of PID, pelvic inflammatory disease, could also increase the possibility of having an ectopic pregnancy. And patients who are having infertility treatment are at higher risk of having ectopic pregnancy. In conclusion, it's important that we, keep ourselves up to date. This presentation basically is to remind you of some of these things, and also to serve as a wake-up call to us to go and read further and read on the topics that I've mentioned. Work on your techniques and listen, read between the lines, look at the clinical indication, listen to what your patient is telling you, and think about your knowledge of anatomy, and use that to guide yourself to where the diagnosis might be. And hopefully that would improve our practice significantly. I've added some links here for further reading. I would send the links through to you as well, through my Oga, and you guys should please have a look at them, and just broaden your knowledge. There's always something new to learn every day, which is why I appreciate the fact that you're all here today, and I wish you all the best. If you do have any questions, please put them together. I believe put them together. My Oga will send them to me, and what I would do is I would make a quick slide of your questions and just answer them as much as I can, and send them over to you guys within less than a week, hopefully. So I think that's it for today. Thank you so much for listening to me. I'm very happy to have been able to deliver this presentation. Also, I do apologize that I'm not there in person. This is due to time issues. I have my commitment, my NHS practice commitment that I need to deliver, so I won't be able to I won't have been able to make your meeting at this time, but probably in the nearest future I'll be able to see you guys in person. Thank you so much, everyone, and do have a great rest of the day. Thank you.